It is with great pleasure that I get to introduce Dr. Becca Fielding Miller, who I think last presented 2 or 3 years ago. It might have been pre-COVID. So I think it'll be really interesting to hear everything that she's up to. And I'll just let me just tell you a little bit about her. So she's an associate professor at the University of California, San Diego in the Herbert Wertheim School of Public Health with a joint appointment in the Division of ID and Global Public Health. She's the director of the HWSPH, that's Herbert Wertheim, Health Equity and Global Health Justice Research Group, and a faculty member of the Center on Gender Equity and Health. Her research is community-driven and examines structural drivers of COVID-19, HIV, and gender-based violence in the US and sub-Saharan Africa, with a focus on the intersection of race, gender, and economic inequality. She holds a PhD in behavioral sciences and health education from Emory and an MSPH in international health with a focus on social and behavioral interventions from Johns Hopkins. She served as a Peace Corps volunteer in South Africa from 2006 to 2008 and as a Fulbright Scholar in Swaziland in 2013 to 2014, and has an adorable daughter who is starting kindergarten. And that's the fact that I can provide.
Yep. If you ever see my kid, it's also very important. You should know you are not allowed to speak about her hair. It is like literally on her name tag, it will say Esther, she, her, do not speak about my hair. It's beautiful. We're not allowed to talk about it. So we're really good at practicing like consent and like it doesn't matter what you're wearing or how you look in public, like people still can't comment on your appearance, which is just really rough modeling for me. And like sweet old ladies are like, it's beautiful. And I'm like, you can't talk about it. Anyway, glad we're recording. Great. I can just riff without the slides, but you want me to be able to keep my place. Okay. So I am feeling super TED Talk with this, but so I want to talk about, in case you didn't notice from all the social and behavioral in what Jill just shared. So I am a public health social scientist. My training kind of sits at the intersection of social epidemiology and medical anthropology. And so I spend a lot of time thinking about how communities are engaging with our interventions, how what research sort of looks like from community perspective, and what folks need and want. I feel like my job in any general meeting is to say, I don't know what people want. What if we asked them? It is amazing. I have a whole PhD in just saying that. So I want to talk today a little bit about this process. I don't have any like pharmaceutical funding to disclose. I should tell you though that one of my funders is sitting over there, and I really like her, and I would want her to be happy either way because she's a good person. So I'm gonna click and see if a thing happens. Maybe. Or I'll use the computer. Okay, try again. There we go. Boop, boop. Okay. This is what I'm going to talk about. Let's see. There we go. So this is kind of going to be in 4 parts. I'm going to talk about 2 different projects that I have been working on in the past couple of years that on the surface might seem a little bit different, but sort of have some common threads in the way that my team and I have been thinking about translation and implementation science recently. So first, I'm going to talk about SASE, the Safer at School Early Alert Project, which is a very large COVID project that we have been doing here in San Diego with elementary schools in partnership with county public health. And then I'm going to talk a little bit about our translation process, because it was probably, you probably heard this number, on average, translational research takes about 17 years from the time it gets from bench to bedside, and we did it in like 15 days. So, and that was a process. And I think we learned a lot along the way. So I'm going to talk about that process. And then I'm going to talk about a much slower study, some work I've been doing in Eswatini, formerly known as Swaziland. You'll kind of hear me use both interchangeably because I'm used to using both words right now. Swaziland is a very small country in Southern Africa. If you look at a map of South Africa, it's the polka dot on the right. There's about 1 million people in it, and it has the highest HIV prevalence in the world, and among the highest generalized incidence too for young women. So I'm going to talk about some work we've been doing there. And sort of the common theme is going to be, what has this process been? So you'll hear me use words like praxis a little bit. So first I'm going to talk about SASSY, which was a lot of work and a lot of fun. SASSY is the Safer at School Early Alert Project. And when we did this, really at the core is this idea that we just think that every child and every family has the right to feel safe at school, no matter where they come from, no matter their zip code, no matter their documentation status. Every child should be able to feel safe at school, and every family should be able to feel good about sending their child to school. That was our baseline. And we wanted to do a community engaged project to rapidly, and I mean rapidly, translate some of the really cutting edge stuff that we were doing at UCSD with wastewater surveillance and monitoring, with rapid testing access. And we wanted to see, can we translate that into communities that have really been experiencing some of the hardest impacts of COVID? So zip codes that had very, very high COVID case rates, areas with relatively low vaccine uptake. Can we take this thing that we know works at a residential campus at UCSD, and can we make it work in elementary schools? So just to give you a sense, these are two maps. This is the county's Healthy Place Index. What you need to know is that we were working in areas that were not doing well according to Healthy Place Index, which basically means a lot of poverty, a lot of air pollution. So like South Bay, south of the 8. Well, not this part of south of the 8. We were in City Heights, we were in San Ysidro, we were in Chula Vista, and we were up in some little pockets in Vista as well. And I also wanted just to point out this map. This is a really old map of essentially redlining in San Diego. And the important thing I think to notice here is that there's a pretty strong parallel between which areas show up on the Healthy Place Index as sort of areas that are experiencing a lot worse health outcomes, are more vulnerable to worse health outcomes, and areas that have like a history of redlining. So when we were thinking about this project, we were being really mindful that the way that COVID is manifesting in our community and across the entire US, it wasn't novel. It wasn't surprising. I think those of us who have worked in HIV for many years could kind of look up right around, I would say June or July of 2020 and say, okay, I think I know where this is going to go, right? Like we have seen the way that infectious disease kind of follows these historical patterns. And so by June, July of 2020, we were saying, well, we know that some communities are going to have less resources and more virus. And so what can we do about that? And how can we act in a way that's really mindful of this history? So this is, I'm not going to go into like all of SASSY, although if you want afterwards, I'll talk about it like for hours. But SASSY was basically, we did wastewater monitoring at elementary schools. It varied from year to year. We started in the fall of 2020 with about 10 elementary schools and 3 or 4 preschools, so Head Start-ish preschools around the county. Everything was very much in flux, so like some of the preschools came and went, but like 10 elementary schools. And we just wanted to see, can we detect COVID in school wastewater? Because some of you, those of you with children or those of you who have been children, might be thinking, not everybody poops at school. And that's true. But it turns out, we talk about that. What's that?
It should be a title of a book.
Not everybody poops at school. We actually had really elaborate like methodology conversations like with Richard Garfield. Like, can we do like a sticker? Like, can we track who's pooping? Like, can we put like a sticker chart outside? They're like, no, we're just gonna not know. It's like we're just gonna lean into the fact that we are not going to know who is pooping at school, and that's for the best. He's so great. But it turns out, so these are some of our, you've probably seen these all over the UCSD campus. These are the Hatch monitors. We worked really closely with Rob Knight, who was just really wonderful throughout this whole process, and Smriti Karthikeyan, who is now faculty at Caltech, because I think she's an actual genius and she's kind and she's beautiful. It's just a really unfair combination. But so we worked really, really closely with Rob and Smriti to take these auto samplers that we've been using on the UCSD campus, put them on elementary school campuses, find just the right place to put them. So we were getting the whole school and not the neighborhood. And they kind of slurped up what they found every 15 minutes from like about 7 to 4 on campus. And we took that to Rob's lab and looked to see if we could find COVID. We also, Rob and some of his PhD students started looking at surface sampling, and that's kind of what you see in this little glove picture down here. So it turns out that because, as we know, COVID is airborne, it also settles on the ground. And so we learned that you could actually kind of swab the ground. We started using a little 8x8 laminated square that the teachers would swab every day. And we learned you could actually detect COVID at the end of the day on this swab. So it was a way of seeing if somebody in the room was potentially breathing out enough COVID that we could detect it on the floor. So kind of a secondary layer that gave us classroom level resolution. So this was all, and we learned a lot from the teachers too. We kind of gave the teachers 2 swabs, one to do where we told them and one to do just kind of anywhere. And we actually learned a lot about how long COVID lingers in a carpet, a long time, it turns out, where you're more likely to find it. And I learned a lot about, turns out not all lamination materials are the same, and engineers get really cranky when you don't know what a material is, was a thing I learned. So this is kind of just what it looked like. We let the kids decorate the samplers. This is one of my favorite. This is Harry Potter. So they just kind of sat on the school campuses. And because we knew there were a lot of reasons why people might not test, like you all know this, you do work in HIV, there's a lot of reasons people might not test. For example, about 1 in 4, 1 in 5 parents pretty consistently told us, if I test positive, I can't afford to isolate for 5 days. Like I can't pay the rent. Or we did some work with the refugee community and we found that people living in very crowded housing were less likely to access testing because if you can't isolate, what are you going to do? So we tried to provide some materials to take some of the sting out of testing too, because if you just tell people that there's COVID, but you don't give them resources for what to do about it, that's not really public health. That's an expensive paperweight. So we tried to provide a lot of materials. We tried to make it very family friendly, just to know kind of what was going on. So it turns out this was extremely accurate. We knew with about 96% confidence if there was at least 1 case of COVID-19 on campus just through wastewater monitoring. We could also do some cool things with correlating the proportion of people that we saw masking to the amount of wastewater. It was really cool. And the schools really liked it. Parents told us they liked it. Teachers told us they liked it. They felt safer at school, which was our goal. So this year we created this online website, this hub to kind of translate this in an even more accessible way. This actually relied on public county data. This was an NIH funded project where we could, again, just make this information really accessible and actionable. So this is sort of a red, yellow, purple, how much COVID is in your zip code right now. Here are some places to get tested. We had a community advisory board. We tried to make it really friendly. And so the thing you should know, 1 is wastewater monitoring is really accurate. 2, websites are not actually great intervention without a system behind them. That's like the takeaway from the interventions. But we also wanted to think about the implementation process and the translation process because, like I said, we feel like we built really good relationships with the schools. And I have been at some fancy universities. I did my training at some fancy universities where that is not always the case. You know, we have, when I did my master's at Hopkins, and like there are stories in East Baltimore where like parents will still tell their kids, like, if you're bad, the scientists at Hopkins will come get you. No, this is genuinely a thing people will say in East Baltimore. Like Emory is in Atlanta, like they still refer to it as the plantation, right? Like Hopkins is referred to as the plantation sometimes. Emory has kind of a complicated history being in Atlanta, like there's a lot going on. And so when people told us that they trusted UCSD, that they had had a good experience and wanted to keep working with us, I didn't take that for granted. And I thought that that was really important. And it was something I was proud of. So we wanted to think about this process of translating something that we came up with at UCSD, not in 17 years, but in like 3 months to communities that needed it the most. And so there's a lot of frameworks for thinking about the process of translating research. REAIM is kind of a classic one. don't ask me what it stands for. I don't remember. Pop quiz. Does anybody remember what REAN stands for? I don't. Yeah. Yeah, we know what it is though. It's a translation framework. Okay, so it's a framework. It's a way of thinking about how to translate an intervention into a new setting. But there's a lot of other ways to think about it. And I think one thing that's really important is thinking when we are translating, what does partnership look like? Where are we translating this to? And what is our relationship with that community? And what does justice look like? Why are we translating it here? What is our goal? I mean, we talk about, well, this place is a higher case rate than that place. Why? Why does that matter? Why are we concerned about disparities? And so we wanted to think about what partnership and justice look like in translational science. And there are these ideas, if you want to get like real into epistemology, which sometimes I'm super into, and like the philosophy of science, there are these kind of bigger ideas underlying what we do. There's this idea of ontology, which is like, what even is reality, which I won't get into very much. There's epistemology, which is what even counts as knowledge. And when I say epistemology, I mean things like a lot of us work in this very positivist framework, which is we have a hypothesis, we test it, there's a concrete reality, and we can define a concrete reality, right? That feels familiar. Karl Popper really likes his p-values. It's great, falsifiable hypothesis. But there are other ideas. There's this sort of constructivist epistemology, which is to say reality is kind of just whatever it is that we're all doing together. If you've ever watched Rashomon, like nobody really knows what's going on. Everybody's got their own perspective and we're all just kind of navigating through that. That's another epistemology. Another epistemology is post-positivism, which is to say there is probably a concrete reality. There is probably no way we can actually measure it. This scale for stigma, we're getting at whatever stigma really is real. We have a scale to describe it, and that's like kind of getting at it, but it's not quite, but like we're doing the best we can. And like, if we do enough qualitative stuff and enough scales and enough blood pressure, we can like kind of surround the idea of it and like kind of know what we're doing. That's post-positive. That's what I mean when I say epistemology. And then there's axiology. And axiology, I think we don't talk about enough because axiology is the idea of what values guide our research. And I'm arguing that we all have values that underlie our research. Some of us are just more explicit about naming them. So we were really explicit about naming our values. And that's why the first thing that I did when I started talking about this project is I told you, here are the values underlying SASE. And we were really explicit about those values. The underlying principle was everybody should feel safe at school. We should be transparent. And so we wanted to sit down and think about from this perspective, like this broader perspective of what does justice look like in translational work? What does partnership look like? We acknowledge that axiology and epistemology are real things that we have to name. We wanted to think about how did this work in SASE? And so we all sat down and we talked about how did our axiology inform our methods and our praxis? And by praxis, I just mean like what we were doing on the day-to-day and how that lined up with our goals and our values. We talked about what did we do that really worked? What did we do that did not work very well? And we reviewed a lot of our notes. We really leaned into places where people disagreed. And there were plenty of places where people were like, that didn't go so well. And we talked about it. And we like coded and reviewed those notes to try and get a consensus of what we did. So this is kind of the idea that we came up with. This was the translation process for SASE. And what we noticed is there were kind of three main cores of what's happening that allowed us to really translate very, very quickly in a way that left everybody feeling good. One really big piece is that it was an emergency and like everybody was in, I will say crisis mode, but I will also say like dynamic mode. Everybody understood we had to act quickly. And that can lead to some not so great decisions, but it can also lead to some really great like flexibility and a willingness to just kind of like just know that the situation is fluid. And that is not always the case with funding and projects. And because of that, our funding was really flexible. Our very amazing sponsors, the county, said, oh yeah, this is what's happening now. So this is what we have to address now. The pandemic is constantly changing. We constantly have to be dynamic to address it. And that let us really follow what the community wanted, what people were telling us was important. We were at UCSD. We have amazing resources. We have Rob Knight's lab. We have Smrti. We had really some of the best scientists and best labs in the country. And we had a lot of willingness to put those resources at the disposal of the community. And then we were able to sort of act as this bridge between our institution and the community, because we really centered our values, and people thought that they saw that we were acting in a way that was consistent. We were trustworthy. We tried really hard to be trustworthy. We really valued relationships. Relationships were super, super, super at the core of this. We worked with Laura Cohn, who is like a brilliant early childhood educator and advocate who has worked here for 25 years and had amazing relationships. I think we had a pretty good relationship with Sam and JD. There were amazing champions at the county level. JD and Sam, again, were phenomenal champions of the project. Dean Anderson was a great champion at the UCSD level. There were people in charge who thought this was important. And we were able to translate knowledge not just from UCSD to these schools, but back from the schools to UCSD. And Rob and Smrti were willing to listen. So when teachers told us, hey, we're noticing that like the virus is seeming to show up on carpets, like even when there's no kids here, we didn't know, like literally nobody knew how long COVID would linger on a carpet. And a teacher like went in one day because she was curious, like did a sample and sent it to us, and we went, oh dang, and like totally revised the methodology because we realized that, oh, because of what that teacher did, we know that swabbing on carpets is not going to work. We listen to schools, so you will hear me use the language of monitoring a lot and not surveillance, because surveillance makes a lot of people in these communities really nervous for good reason. They have a really bad history with government surveillance, and so we listened to the language of communities and we translated that back, and we had partners at the institution who were totally on board with being translated to, not just translating at. And I think that's really important. And I think that this model is not a way that we think about research translation very much, but I think the fact that everybody left feeling good about this project, that we have relationships that we can keep building on, and we came up with a really, really, really cool technology and like validated something awesome, is an amazing win, and not like a constellation of factors you see very much. So we explicitly named our values early on. We used a community-centered research approach that prioritizes open communication, health equity, empathy, anti-racism, praxis, and stakeholder autonomy. This is all kind of what I already went over. It was a public health emergency. We had great resources, flexible funding. Oh, this, by the way, in case you're wondering, this is Leonard. Leonard is our mascot. Leonard is canonically non-binary, but only internally because we don't want to freak the parents out. But just so you know, Leonard uses they. This is mostly what I already went over. We had amazing champions, and we translated in both directions, and we had good relationships. Okay, so that was SASSY, and I hope I did it justice. Oh, look at me with the timing, nailing it. So this other project, and this is gonna link up, I promise. I'm gonna stick this landing. This other project is in Eswatini, is in Swaziland, and it's called hashtag Game Changers, which the kids named, not me. Bagutmuli Betinfo, which means they are changing things. Same thing. This is a sexual violence resistance intervention in Eswatini. The reason that I am talking about a sexual violence thing at ABRC is, I think a lot of us know, sexual violence and HIV are really deeply intertwined epidemics. Women who experience sexual violence are more likely to have HIV. Women with HIV are more likely to experience sexual violence. These things are really hard to disentangle. And we were doing this on a college campus. And in Eswatini, women like 18 to 25 have the highest incidence in the country, in a country that has a prevalence of about like 33%. So this is an extremely, I guess I would say, high need community. This is a community where we need to be trying all of the things. And so I work really closely with some faculty at the University of Eswatini, and we said, let's see if we can figure out a program for sexual assault resistance for university women. And it turns out there's not a lot of great evidence for how to prevent sexual assault on college campuses. There is one program. It's called EAAA, and it was developed in Canada. It's called the Enhanced Assess Acknowledge Act program. And it has been shown, this is a thing from the Lancet, a little screenshot from, New England Journal of Medicine, to reduce experiences of sexual violence by 50% among women who go through this program, which is wild. Like, we don't have data on anything else working even a little, and this program reduces experiences by 50%. It's amazing. And so there's been a real push to adapt this at universities all across the US and Canada, and there's some kind of initial forays into doing it globally. I think the Air Force has taken it up to start thinking about their thing. It's a really cool program, and it's really bracketed around the idea of women are socialized to prioritize other people's comfort over other people's feelings over their own safety, right? That is just a way that like gendered socializing happens. And so this thing is kind of predicated on helping women acknowledge that they feel unsafe and that they are perhaps correct to feel unsafe, and that they have the right to speak up and to protect themselves. And if they need to, they have the right to like physically protect themselves. And so there's a small physical self-defense component, which they rarely use, but is really fun to see them practice. There's like a move where you can like do kind of like a hip thrust and like send somebody's head through a wall, which is like pretty rad. And so it's a mini workshop setup. You do about 20 women. It's 3 sessions of about 4 hours each. So it's a 12-hour program. And it's really a resistance framework. So you hear me say resistance, and that's because there is sort of this history of this type of sexual violence, safe physical resistance programming kind of being a little victim blamey, like, oh, if you didn't fight hard enough. And that's not what this is doing. This is really predicated on the idea that all survival is good. Whatever you did in the moment was fine. And also, here's some other strategies you can use, but like whatever you did, whatever you do is fine. The only person who can prevent a sexual assault is the perpetrator. That's it. Here are some strategies that you can use to maybe resist when a perpetrator makes the decision to perpetrate. So it's a cool framing. And this is the girls came up with, I shouldn't say girls, they're like 19 or 20. The young women came up with, here are all the ways, a lot of different ways to say no in Siswati, in Swaziland. No, Khaibo, which I really love, which is, there's no translation. There's no translation for Khaibo. Angifuni, which is I don't want that. To, which is na. Mani, which is like, hey you. Or Sugala, get out of here. Ngibuya, I'm coming. Like, I swear I'll be right back. Futsek, which is exactly what it sounds like in Afrikaans. So this was some of the like swag that we passed out that the women really liked. And so one of the really interesting things about this is because it is an education intervention to empower women. So we're talking about how women are taught to ignore their own instincts. And we're doing this in a scripted, facilitated small group. And so there is this model of thinking about education called critical pedagogy. I'm pretty sure it's illegal in Florida now. It was, if you've heard of Paulo Freire and pedagogy of the oppressed, he's really kind of where people think about the origin of this. It was really refined and thought about a lot by bell hooks. The crux of it is there's kind of 2 different ways that we can think about educating. You can think about this kind of banking model where like you sit there and like I install knowledge into your brain while like you hold still and I like hold forth. We're kind of doing that now. I'm sorry. But there's also this kind of like conversational model where it's really the conversation between the teachers and the learners where like new things come up, we sort of mutually discover, and like I know more about this than you because I'm the teacher, but it's really in the conversation that we kind of together learn new things, that the students really kind of make the discoveries themselves in a facilitated way. And it really encourages people to question the world around them. So problem posing. So if I'm teaching you about, for example, COVID case rates and structural determinants of health, I encourage you to look around and be like, yeah, why is it that nobody I know feels good going to the doctor? What's that about? Like, I encourage you to bring in your real world experience, and I value that because that's a part of the learning process. Um, and so when we think about an empowerment intervention, obviously we would want to think about an empowering way of teaching, because there's a little bit of a tension between you sit there and be educated, be empowered. Like that's kind of a weird, there's a tension there. And so we wanted to think about so we were going to do a whole RCT, but then COVID. So this all relates back to COVID. So about 20 women went through this Game Changers program that we adapted from Canada to Swaziland. And so we wanted to talk to some of these women about their experience with this empowerment sexual assault resistance intervention. And so we did semi-structured interviews with about 7 participants and 3 facilitators, not huge, but like honestly who we could track down in the middle of COVID. And we wanted to think about it in terms of this kind of critical pedagogy approach, because if the intervention was grounded in the idea of power, we wanted to think about how we were delivering it with the idea of power too. And we noticed some really interesting things when we listened to what the participants and the facilitators were telling us with this framework of paying attention to power. This is all my PhD student, Araz Majnounian, and a former student and now staff member, Anvo, who are like actual geniuses. So they're writing this up for social science and medicine. So what this is this is kind of a matrix here where on the left you see like distal, so like really like upstream drivers of health disparities. I guess that's the right. Upstream, downstream. On the top you have like sort of participant driven conversations, and on the bottom you have research driven conversations, interventions. And so we noticed that when people were talking about this, women really wanted to talk about like, okay, this intervention was really great, but like, what if he's paying my school fees? Or this intervention was really great, but like, the cops just laugh at me and ask what I was wearing. And so they wanted to bring up these ideas, these like really big framework things that are true and important, and that the intervention is not designed to address. And the women who created it would agree, the intervention is not designed to address these things. But the women wanted to name these things. And those were really participant-driven conversations about upstream factors. But there were also kind of more immediate things. There was a lot of really great conversation about like catharsis and solidarity and like feeling sisterhood. This idea of collective empowerment that was really lovely. And so that was participant-driven and a little bit more like of an immediate outcome. And then there was sort of more researcher-driven immediate stuff like these physical self-defense skills, which they loved, which are, again, extremely fun. And so we started to think about, when you consider sort of who has power in the intervention and where the intervention is acting, it sort of also suggests this other quadrant, which you notice is empty over here. But like really, you could get into this place of like really upstream researcher driven stuff, which is honestly just kind of patronizing. Like, did you know it's bad to be sexually assaulted? You should stop doing that. Like, and I'm being facetious, but I think we've all seen these things where we're like, well, we'll just like educate you about why it's unhealthy for you to be poor. Okay, thanks. Like people know, right? There is this, and so when we thought about this in terms of what power is doing and what it's acting, we noticed that there is a need for interventions to be replicable, right? Like that's how we decide that something is worth knowing. That is our ontology. That's our epistemology. You have to be able to replicate something and test it with an RCT like it was a drug. And that type of model is really good for like stuff that's a little more researcher driven and immediate. Really good for this because the facilitators literally read off a script. If they go off script, all of a sudden you can't replicate that, right? How do you test it? But like this is really, when we talk about the intervention is about power, we're really trying to be up here, but you can't replicate that. That doesn't work in a biomedical model. And so I don't have a solution for that, but it was just a really interesting way to think about what we were doing, what the women were telling us, and how do you do an intervention that is fundamentally aimed at targeting a power structure in a way that potentially replicates other power structures like colonialism, right? Like I'm here from San Diego telling you what to do in Swaziland. And how do you think about gender and power without thinking about colonialism and power or race and power? They're all kind of intertwined, which is what Bell Hooks would tell us because she was world smart. So I am actually not here to give you answers. I don't know. These are just the questions that I'm asking. And these are the questions that I'm thinking about right now. What does it mean to script an empowerment intervention? Especially in a context where our way of knowing is a randomized control trial. How do we do that? What would it look like if we talked about our values from the start in the same way that we talked about our study design and our outcome? This is why we're doing this. This is what we think is important. How do we think about praxis when we do health disparity research? Is the way that we are doing our work, does it replicate power structures or does it disassemble them? And it feels scary and bad and uncomfortable to give up power. And sometimes we feel like it's not even possible to do rigorous research if I, with a PhD, am not like completely in charge. We literally just had a reviewer on a CBPR study say, why are you letting the high school students come up with the questions? That's a flaw. And I was like, no, that's the premise. But like it was dinged as a flaw in the approach. And I think the other thing that's really interesting to think about is when we talk about translational research, like what does that translation imply? Does it imply that we're taking a thing that we came up with in Rob Knight's lab and like giving it to you, you're welcome, like hold still while we figure out how to give this to you in the right way? Or does it mean that we are like literally listening back and forth and translating back up from the community to the lab for like, well, here's what the community needs. So what if we designed for them from the start? Like, what if translation was a two-way process and everybody's language was valuable? I don't know. I am just here to give you questions and that's all I have. So thanks. That's it. I don't have answers. I'll take more questions though.
No, you followed the rules beautifully because we
Yeah.
want to have some time for dialogue and
Yeah.
then people can network a little bit.
Yeah.
I will open it up to the group here or anyone. Let me see if there was anything that came through. Katie Riggs did make the comment online that she loved that you avoided the term surveillance.
Yeah.
And I guess to sort of further that, was that recognized by people who were part of the studies, or is that more on, sort of our side and the terminology or your side terminology that's used?
I think that comes, I think that we did that from the start, and that's because another reason that we were able to sort of jump into this so quickly, I talked about relationships, and it's because like I live here, right? Like I try to be pretty involved in the community. So I have friends who like I have a friend who runs a refugee advocacy organization, and they are very vocal advocates about surveillance ordinances. And I work with them really closely. Like I am involved I am involved in my community not just as a scientist but as a person. So like I do local advocacy work. I do things that involve electoral politics that we'll talk about not here. Like I try to know people and I try to know what's going on, and I think I try to also be a part of this community. And so that was assumed from the beginning. It's like the word surveillance is just not going to be it. And it's because we live here. We know that. Yeah.
Quiet group this morning. I could ask another question.
Please. Or if anybody like can answer these,
Yeah.
I'd be all in.
Well,
Please tell me.
I mean, I think the question is your second question of what would it look like if we acknowledge axiology. Isn't one of the bigger questions what would happen if the NIH or other funding groups acknowledged axiology? Because isn't that, I mean, is that part of what you're thinking about?
Yeah, I mean, I think that it's there no matter what. And there is sort of a move in some of the social science and the more social sciencey literature to start adding like positionality statements to papers. And I think that's more like qualitative sort of stuff and in the more sort of like very social sciencey journals, but it's sort of like trickling up from anthropology. And I think positionality is not quite the same as naming your values, but I think that the conversation is starting. I also think that a lot of this is fundamentally about power, and I think it would do some really interesting things if power named its values to just where the money is going and what we're doing and who's in charge.
Excuse me, forgive me if I missed this, but for the Safer at School program,
Yeah.
I was just curious, what is the future? Is it just going to be ongoing, or? Yeah, I mean, I guess, yeah. What's going on? I mean, it sounds really neat. So
Yeah.
Yeah.
Because I think it's
Oh, yeah.
Oh yeah, it says Dr. McCutcheon said, how were the results of the monitoring of schools used to intervene?
Yeah. So I'll answer the second question first. So every day, schools, the principal got a PDF with the results, and we tried to make it real. We spent a lot. Speaking of relationships, like employee number 3 at Tableau happened to be a friend of a friend, and he retired quite early because he was employee 3 at Tableau, and so he just like helped us make these amazing visuals for fun. And so every day the principals got these like pretty clear visuals of pretty complicated data of what was happening at their schools, from the classrooms to the wastewater. And so the principals knew. We had sort of packages of like information, like health education packages that were appropriate for like Dojo, if any of you have like kids in school, like all those little apps that like your teacher will use. So we tried to let people know very quickly if there was a case on campus and make sure they knew what resources they had access to. In sort of the long term, we used some of the data. It sort of fed into the word for when the virus mutates. Kraken and Omega. Shoot. Variants. Thank you. Variants. We used it for some of the variant surveillance. It was part of that bigger pool. We actually saw Omicron at one of our schools within 2 weeks of it showing up in the county-wide wastewater, which was really interesting. So that was like a phone call over like spring break to a principal, like, just so you know. And so we tried to do very quick, very practical interventions. We also, the hub was sort of seeing if like on a more school-wide level, we could kind of inform school-wide behaviors for like, will people mask more? Will they test more? Kind of. Turns out a website, it's not a great intervention. Principals are better. As for the future, so we have a lot of data, and we are working, we're trying to actually set up a youth-led participatory data analysis project. That was an R21 that a reviewer just said, why are kids doing this, like, as a weakness? So we're rewriting that because we think that it was really cool that our partner schools really felt like they were doing research with, not on. That was important to us. And so we want to keep doing that. And we collected all this data about these kids and their families. And we really want to give those kids and families kind of a chance to shape the story that we can tell with that data. As for wastewater surveillance, I'm given to understand the pandemic is over. So, you know, that's done now, I guess, sadly.
anyone else either here or online?
I was wondering if there was a
This is
notable
JD
change.
Malone, and I had the pleasure, I'm an infectious disease physician for the county. I had the pleasure of working with RFM and the entire team, Dr. Tweeten. And I just like to say that, you know, sometimes crisis, and I think crisis is a good, public health emergencies really bring out the best, in that we had an absolute multidisciplinary team, as you think about that, and that also we communicated with each other and we trusted each other. And this was everything from the university, the county, to the educational people. And I think that was really one of the keys. And even we were stomping through all kinds of different places with utilities, and was an absolute team effort with a common goal. Over.
I learned a lot about plumbing. I also think it was really unusual that a social scientist got to lead a project this big. I think this is often something that would be led by a physician or an engineer. And I felt really lucky that my background is, again, more social science, community engaged research. And so I think it was unusual that we got to really center that approach with the other stuff kind of as the co-investigators, rather than me like jumping on 3/4 of the way through and being like, wait, actually that's not going super, like, how do we fix it, as opposed to like, how do we design for it. It was nice. It was unique.
Doctor,
just
you were a very
wondering-
good leader. You were a very good leader.
Thanks, JD.
I was wondering if the research at the university, if there were noted cases where violence was averted or that you learned about.
Yeah. So what happened was we did the first round in February of 2020 was when the first young women went through this program. So it was a little bit of work to even track down these 10, because then the university went online, which is a whole thing in Eswatini. We don't have that data. We are applying for funding to like do this more, to expand it. One thing that was really notable is they really liked the sex ed component. There's a very cool sex ed component, which I thought would be a little uncomfortable culturally, but they loved it. And one woman said, I feel like all sex ed has been about HIV forever. I love that this is not about HIV. It's not a big deal if you get HIV. It's like the flu. You can just get medication. What I don't want to be is pregnant, because people can see that. And I was like, okie doke. That's I file that comment away. So I know that in other contexts, yes, absolutely. This is being done at Stanford and in Florida and in Canada and in New Zealand and in South Africa. We don't have anecdotes for this particular project, though. Yeah.
Last question, or at least for now. Back to Sassy. What resources were available to school staff and students to deal with detection of cases?
Yeah, so it depended on the year. So in the first year, we did this as a validation study, and this was actually, I think, the reason that a lot of schools wanted to sign up, is we were providing weekly diagnostic PCR testing to everybody on campus who was willing to sign up, which was a whole thing. I got very familiar with the IF system. And so we actually had, by the end of the 10-week validation process, about 70% of people who were on campus regularly were getting a diagnostic PCR test once a week with us. And so we ourselves did not have like income replacement or anything beyond the diagnostic testing, but we tried to be really good about curating what was available and making that very easy to access for parents. And it was really nice that we were working so closely with the county, because they could just tell us, here's what's available, and we could like put it in a friendly multilingual flyer. By the second year, we were doing some testing, but many schools had moved into their own testing approach. Most schools, like San Diego Unified, had their testing program. Other schools were using antigen tests. And so it really varied from school to school, depending on if they already had a thing set up, if they wanted more support from us. So we were able to move out of like provision of healthcare, which was a surprising place and a lot of work, more to, again, sort of that curating space. But we had a lot of town halls. We tried to be available to answer questions as we noticed new things coming up. We tried to make sure that we were always providing like accessible, accurate, multilingual information. And anytime that like schools or teachers or principals or parents like had questions or issues, we tried to make sure that we were really, really available to quickly answer those and address them.
I think nothing further.
Okay.
So no, this is great. Now people can talk and do what they need to do. And people online, you get 9 minutes back in your life. Thank you so much for being our first summer speaker, or I guess, well, our first August speaker
Yeah,
and
I'll take that.
returning from our break.
I'll
This
take
was
that.
a really nice, a really cool presentation, and interesting to hear about both of these studies.
Yeah.
Thanks, Becca.
Yeah, thank you. Well, fun.